Actually, I'm very happy to present in CardioAlex for the second time in a row. It's my great pleasure to meet my colleagues and my friends from Alexandria. So my talk will be going to add the point of inappropriate prescribing in heart failure. First, I'm coming from University of Hertfordshire, which is the first British university in Egypt. We are full mirror of UK. Can we go, please? Okay. There is no conflict of interest. As you may know, that heart failure is one of the leading causes of hospitalizations for people aged 65 years young, and also 25% of people or heart failure patients aged 65 years young can be re-hospitalized within 30 days of their first discharge of heart failure diagnosis. 2021 version of the guidelines recommended to prescribe 4 pillars for heart failure patients: ACE inhibitor, RASI, evidence-based beta blockers, MRAs, and sodium glucose transporters. Shall we prescribe all of them? Yes, to improve survival, improve patient quality of life, and also to reduce cost of care and hospitalization. طيب السؤال الثاني هو انا ابدا واحد ولا should we go all of them؟ الجايد لاينز كانت واضحه جدا في الحته دي، وده كان خلاف مع شباب اسكندريه السنه اللي فاتت. ايوه all the 4 should be started from scratch. طبعا ضغطك متظبط، الكلى متظبطه، ابدا ال4. وعندنا نتورك ميتا اناليسيس بتاعت كوماشدا في 2018 قالت لنا ان وجود ال4 مع بعض للمريض are very beneficial. طيب لكن احنا عندنا مشاكل. Are we prescribing the guidelines as recommended؟ ده دايما في سؤال. طيب احنا يعني I did a piece of paper في Ireland عن effect of clinical pharmacy in optimizing heart failure prescribing at discharge، وكانت النتيجة ان 30% of the Irish patients are discharged upon guidelines recommendations. طيب في مصر حقيقي في مصر كان عندنا مشكله كبيره جدا في البيتا بلوكرز، ودايما عندنا خوف من البيتا بلوكرز اند كونجشن، فالمريض بيطلع من غير بيتا بلوكرز. لكن عندنا very high peak of lazilactone which is spironolactone with furosemide. طيب ما ممكن المشكله دي on small hospitals؟ لا، عندنا الريجستري بتاع السافاريزا in 2019 he did a very nice observational study over 11k patients, and I found that 50% of patients are prescribed inappropriate dose of spironolactone. طيب what about US? Another database of 12,000 patients لقيت ان 1% of heart failure patients are discharged on target dose as recommended by the guidelines. طيب السؤال الثاني are we prescribing safe medications to our heart failure patients؟ ما هو ممكن في مريض الهارت فيلير is polyclinic patient، يعني بيروح لدكاتره تانيين غيرك فانت مش قادر تسيطر عليه. الحل خلي بالك من نقطه اسمها inappropriate prescribing where you can prescribe a wrong indication او a medication that may cause an adverse drug reactions. بس كده لا. The failure to prescribe or to achieve the full benefit of heart failure guideline directed medical therapy for whatever reason is considered as inappropriate prescribing. فبالتالي we have another gap in practice and guidelines. طب هو الموضوع ده فين في الجايدلاينز؟ في version 2016 we have a brief note about the medications that are classified as class 3 which are considered as harmful medications. طيب فاحنا بدأنا as pharmacotherapy working group في اليوروبيان سوسايتي اوف كارديولوجي بدأنا نفكر طيب ما هو دلوقتي المريض ده بيروح ل other types of doctors نعمل ايه؟ فبالتالي we created or we designed PEP-HFrEF potentially inappropriate prescribing in heart failure with reduced ejection fraction to be the first evidence-based prescribing review tool with the more specific than Beers criteria and stop-start criteria, taking into consideration the Egyptian market of medications. طيب, this is the paper. We published the paper in 2019. We considered medication omission, reflect current prescribing practice, which is very important for us, and the application in clinical practice. فانت ممكن بتقولي كلام نظري زي الجايد لاينز وانا مش عارف اطبقه. تمام؟ طيب. What else? we studied the different mechanism of action that may lead to heart failure mortality or exacerbation or development from scratch. وبدأنا نجمع الداتا دي from the Egyptian Medical Agency والداتا بتاعت pharmacovigilance بتاعت مصر كمان as part of the European Society. وهنلاقي حاجة زي مثلا الإيتراكونازول أو الأنفوتيرسين بي yes they may cause death in heart failure. طب is it pharmacological agents only? No, there are some classes and for example many patients are prescribed on dual loop diuretics. ولقينا حتى في study عندنا في القاهرة ان patients are prescribed loop furosemide and examide for the reason of short onset of action and long onset of action. That's totally not pharmacologically based. Okay. حاجة تانية برضو كان بتتكتب زمان which is non-dihydropyridine calcium channel blocker with a low dose of beta blockers. بس طبعا ابتداء من سنة 2000 الموضوع ده خلاص ما بقناش نكتبه. تمام. في حاجات still we don't know لكن لقينا ليها ريبورتس زي ال SSRI في وجود بيتا بلوكر they may cause mortality and major bleeding. وحقيقة احنا شفنا حالة زي دي السنة اللي فاتت في المستشفى وعملنا منظار فوق وتحت عملنا كل حاجة وما كناش عارفين هو ايه سبب البليدنج اللي بيحصل. طيب عايزين بدأنا نطبق البابافراف تول في الكلينيكال سيتنجز في ايرلندا ومصر وتشاينا and the range of inappropriate prescribing were from 6 to 24%. قلنا لا كده still we are very small number of patients. Let's go to a large database and currently we already applied the tool on 51,000 Swedish patients. We found that neuroleptics, major tranquilizers, are the most prescribed PEP-HFrEF items. Second, systemic corticosteroids. فبالتالي بما اننا clinical pharmacists, please don't take it easy to prescribe corticosteroids to your heart failure patients. طيب, regarding the clinical outcomes, take care, yes. If the patient is prescribed at least one PEP-HFrEF item, you are putting them at risk of mortality by 2-fold than other patients. طيب, where are we now? البيبر دي موجوده دلوقتي في European Heart Journal سافاريزا. وحقيقه عايز اشكر شباب الجامعه عندنا بتوع كليه هندسه ان we are turning our prescribing review tool into mobile application to facilitate the application. Thank you and I hope I was on time.